on. And it's a great pleasure to introduce our guest speaker today. It's our friend here, Tom Allerton.
Well, the picture's covered up by then. No, keep it covered up.
We did suggest it looked like sort of one of the most wanted from crime watch UK. But I see it's very difficult to find photographs of these people. So, and he hasn't sent me an alternative, which I give him the opportunity to do. So tough. Tom is the specialist respiratory physiotherapist and principal service leads for urgent care therapies at the Royal Bolton Hospital. I first met Tom when I went on the pulmonary rehab course over 5 years ago now. And it's through that course that the beginnings of the pulmonary support group in Bolton started. So it gives me great pleasure to hand over to Tom. And if you want to talk about mucus clearance now, hopefully this will. Just flick that one down the side.
Flick it down.
Yeah.
If you flick it up, does it go back?
Yes.
Oh, there you go. Well, can I move this out of the way?
Yes.
How are you going to try it?
Well, got nice and boxy.
Well, first of all, what an absolute pleasure to be here this afternoon. It's really nice to get a break from the hospital. So it's really nice to see you all. So thank you very much for inviting me, Steve, and thanks for being so patient. And I must admit that photograph that Steve managed to pull off the internet from somewhere, I think it was a still from a video that I was in probably 10 years ago. So I look a little bit younger, but I look a bit gormless because I think I'm mid-speech when the still was taken. So there you go, I'm a little bit older now, certainly a lot greyer, and probably a little bit more exhausted, but there you go. That's just life when you've got 4 teenagers. One of them who has left home but is now back with us again at the moment. So I'll just give you a bit of background about who I am and what my experience is, and then we'll talk a little bit about lung congestion and chest clearance. So I have been a physio for 21 years now, and rather unusually, I've been based in Bolton for all of my 21 years. So I've been based at the hospital for nearly all of that time. And it really is quite unusual. Although there are probably 3 or 4 of us who have done the same sort of thing. And that tells you something about what working in Bolton's like, because it's a very fulfilling trust to work in. Steve's right, my job title is Principal Service Lead for the urgent care therapy team or the inpatient therapy team. But I am still a physio, and I'm a respiratory physio. And although I'm not as clinical as I once was, I still have a clinic once a week. I still help out at pulmonary rehab occasionally. And in fact, I've come here via a patient's house because I've done a home visit today over the lunchtime period. So I am still an active physio. Although I must admit, a lot of my time now is taken up managing a rather large team of physios and OTs in the hospital. I think there's 42 people in my team now. And if you're ever admitted to the hospital and you are anywhere between A block and D block, that'll be my physios and OTs that are looking after you. So all you need to do is you need to say to the physios and OTs, I know Tom, and then we'll make sure we look after you even more than we would do in normal times. Okay. So please do name drop. I know Tom Allerton to the physios, and we'll come and make sure you're okay. I even had the pleasure of working alongside Carol for many years. So
And also Jackie.
And Jackie, who works here in the Wellbeing Hub as well. So that's a little bit about me. Most of my career has been spent looking after people with lung problems. Lots of work with people with COPD, lots of work with people with asthma, lots of work with people with bronchiectasis, and probably less work with people with pulmonary fibrosis. But that doesn't mean I haven't got experience of trying to help people navigate what is a very distressing illness in many ways for some people. And most of the work we do is around managing breathlessness and different breathing techniques to help control breathlessness and making sure people find ways to maintain a quality of life with regards to breathlessness. But we do know that everybody, regardless of diagnosis, can often have a problem with congestion in the lungs. And that's specifically what Steve's asked me to talk about today. So as a respiratory physio, your phlegm is my bread and butter. So that's a nice little thing. I'm glad you've had your lunch a while ago anyway, and you've got time to digest that. So your phlegm is my bread and butter. But the lungs are rather fantastic things. And the more you read about the lungs and the more you read about the human body, the more amazing the statistics are. So before we talk about chest clearance particularly, I just wanted to give you some facts and figures about the lungs, because honestly, it blows my mind every time I think about these things. So the average person in a day will breathe between 10,000 litres and 12,500 litres of air. That's quite impressive. Yeah, 10,000 to 12,500 litres of air a day. The average person will breathe between 5.2 million breaths and 10.5 million breaths every year. That's also quite impressive, isn't it? This is possibly even more impressive. Inside your chest, inside your lungs, there is 1,500 miles of breathing tubes. 1,500 miles of breathing tubes inside your lungs. Absolutely incredible. And within inside your chest cavity, there is 1,000 square feet of lung tissue. Very, very thin, but 1,000 square feet of lung tissue. Quite remarkable. The human body is absolutely amazing. And I've been reading a book by an author who isn't known for this kind of writing. Have you heard of Bill Bryson? So he normally writes stuff about, not from a small country, didn't he? He writes sort of travel books, if you like. Well, he's written a book about the human body, which is fascinating. I'd encourage you to get it and have a read of it, but there's a really good section on the lungs. And this is absolutely incredible, okay? And I'll leave you to digest it just for a moment afterwards, okay? So Bill Bryson obviously done his research and says that for every breath that we take, 25 sextillion molecules of oxygen are exhaled. 25 sextillion, and for those of you that are good at maths, that's 2.5 times 10 to the power 22. That's an awful lot of oxygen molecules, isn't it? Okay, and that's with every breath. So Bill Bryson goes on to say, therefore, with a day's worth of breathing, you will in all likelihood inhale at least one molecule of oxygen from the breath of every person who has ever lived. So at the subatomic level, we are all, in a sense, eternal. So there you go. Absolutely fantastic. Yeah? And the lungs wonderful. Now there is a point to me saying all of that. Okay, there is a point. Because clearly, all of those breathing tubes and all of those blood vessels and that huge surface area of lung tissue that's inside your chest and that large volume of air that we are breathing means that a lot of stuff out there in the air that we breathe finds a way into our lungs. And we know it's not always fresh air. What else do we breathe? Smoke, car exhaust, pollution, fumes, and all of that stuff is getting into our airways and into our lung tissue. So it's a good job the body's got some natural defences. Fair enough? We're going to talk about some of the lung defences in a moment. Okay. I think I might have talked over a number of slides already. So there you go. Look at that, 25 sextillion molecules of oxygen. Quite remarkable. Okay. Anybody got any idea what that might be? Oh, you are so educated. Right. So how do you know that's alveoli? But have you done your own research, or have you learned that from here, or have the doctors taught you about it, or is it a combination?
We used to do scuba diving, and
Right.
we had to learn about that.
Okay. Okay. So for those of you that don't know, these are the tiny little air sacs that are the reason that we have lungs. Okay. Because it's in the, or around the outside of the air sacs is where the air that we breathe in, and therefore the oxygen that we breathe in, has the opportunity of meeting the blood that's flowing around our body. Okay, because we've got tiny little capillaries that around the outside of those air sacs. So that's the point of having lungs, because it allows air and oxygen to breathe into the lungs, find its way into the air sacs, and then carbon dioxide can go in the opposite direction and out of the capillaries, and then we breathe it out in the opposite way. So that's the only point of us having lungs, so that oxygen can combine with blood and carbon dioxide can go in the opposite direction. Okay. Any idea how many of them there are in a normal set of lungs? Ooh, I like football fans. Yeah. I'll get Tom in football. Well, sadly, I'm a Bury fan and we don't actually have a team anymore. But there's hope, because the sort of Phoenix Club is joining with the original supporters club, so we're hoping that we might be next year. So they look like a bunch of grapes. But would you believe there's 300 million alveoli in your lungs? Incredible. 300 million alveoli. Tiny little air sacs where the lungs and the blood exchange oxygen and carbon dioxide. And you're absolutely right. The alveoli surface area is as big as a tennis court, not a football pitch. Yeah, okay.
Some sports.
Yeah, but tennis court's really big, actually. It's really big, isn't it? And we breathe in enough air and pollution to fill a swimming pool. Okay. I'm going to flick through that slide. Just some technical stuff around ventilation and diffusion and perfusion. That's just the blood flow. Okay, so we then come to, so we've established that there's loads of air being breathed into a massive amount of lung tissue. And if we had no lung defences, we would be at risk of infection with every breath that we took. So, do you have any idea of any of the natural lung defences that the human body has? There are little hairy bits, and we'll come to that. Okay. What's the first line of defence when we're breathing? The nose, absolutely. So the nose should be the first line of defence. And what does the nose do? Helps to filter. Someone said filter in the room, didn't they? Absolutely. Helps to filter the air that we breathe. There are hairs in your nose that are quite big. You know, some of us men who get to a certain age tend to have particular hairy noses, don't they? So there are large hairs, but there's also smaller hairs that help to trap any larger particles of what we might be breathing in. But the nose also helps to humidify the air that we breathe, because sometimes if you breathe cold air, it can tighten your chest up. So it humidifies, it warms, and it moistens the air that we breathe. And believe it or not, if you breathe through your nose, you actually produce a bit of nitric oxide, which helps to disinfect the air that you breathe. So nose breathing is fantastic. It's quite difficult for people with pulmonary fibrosis, but there we go. Okay. So the first network is the filters that we have, and the nose is the best filter. What other lung defences do you think we might have? Anybody have hay fever? Holland feels to be really high today. I'm struggling today a little bit. What do we do when we come into contact? If you've got hay fever, you come into contact with pollen. Absolutely. So we've got a network of reflexes, don't we, that help to protect our lungs. So it can be sneezing, but it can also be coughing. Okay, natural reflex mechanisms that help protect the lungs from inhaling things that are harmful to us. Okay. Any idea what the next line of defense is? Gotta be mucus. Yeah, you're Flemish, butter, absolutely. So the body produces mucus throughout its entirety. So, you know, if you rub your eye and you've got a little bit of sticky dust in your eye, that's mucus. But we don't tend to call it mucus once we're talking about the mucus that's produced in the lungs. We can do, it's not a problem, but to differentiate it, we normally call it phlegm or sputum. Yeah, so sputum and phlegm are both forms of mucus that are related to the lungs. Absolutely. So in a normal, healthy breathing tube, there are tiny little cells called goblet cells, and they produce a small amount of mucus, and that is absolutely perfectly normal. And in fact, it's required because it's that mucus that helps to trap some of the particles that we breathe in that we really don't want to be in our lungs. Okay, perfectly normal. Any idea how much mucus a normal pair of lungs produces in a day? Well, it actually, depending on where you read, it's anything from 300 millilitres, which is about a can of Coke. Yeah? Well, for some people it's half a bucket. Normally they've got a condition called bronchiectasis. Bronchiectasis, yeah. Anything up from 300 mils can of Coke to a litre. So a litre of water is 1.75 pints. That's quite a lot of mucus being produced in the lungs, isn't it? And that's happening all of the time. And every time you clear your throat and swallow, that's you getting rid of that mucus. Okay. So we've got our filters, we've got our reflexes, we've got our mucus, phlegm, sputum, whatever you want to call it, doesn't really matter. What's the last line of defense? Anybody know? There's some very learned people in the room. Not specifically, although that is incredibly important, of course. Anybody heard of cilia? Yeah? What's cilia? The hairy bits inside the breathing tubes, absolutely. Yeah, so cilia are little tiny hair-like projections that line the inside of your breathing tubes, okay? And again, they are essential because it's the cilia that beat at 20 times a second. I mean, I can't do that 20 times a second, but that's what they do. And they pick up that mucus that's been created and they flick it up your breathing tubes. And that's happening all of the time. It's a good job it is happening all the time, because if it wasn't, that mucus would be building up and building up and building up within your breathing tubes. And eventually the alveoli would get clogged, and therefore you wouldn't be able to get that exchange of oxygen and carbon dioxide. Okay. So there's a special fancy word for what happens when cilia and mucus work together to clear your breathing tubes of phlegm. It's a cracker. You can remember this one, you can use it in conversation. It's called the mucociliary escalator. So there you go. The mucociliary escalator, but it does exactly what it sounds, doesn't it? It picks up the mucus and moves it upwards, because that's what an escalator does. So there you go, the mucociliary escalator. So a combination of all of those things is what keeps your lungs less at risk of inflammation and infection. Okay, so the filters, the reflexes, the mucus, and the specialized cells, the cilia, that pick up the phlegm and move it. Yeah.
So actually what happens, how does the fibrosis, and what is that? Sorry, I'm a pain.
No, you're not a pain at all. No, so lung fibrosis is around scarring of that lung tissue. where the tissue stops being as elastic as it once was and becomes more rigid, which means that there is a greater restriction to movement of the of your lungs in total.
It gets scarred.
Well, sometimes we don't know. Sometimes it's because it can be a direct result of taking particular medication. Sometimes it can be as a result of inhaling things that cause scarring, like asbestos can do it, and there are other things that might do it all the time. But it's one of the peculiar things about pulmonary fibrosis is we often don't know why the lungs have got scarred in that way. The other thing that scarring does, and that fibrosis, the thickening, means it's harder for the oxygen to get from the air that you breathe into the bloodstream and the carbon dioxide to go in the opposite direction, because literally things are thicker, so it's harder for that process of diffusion to take place.
Tom, with all that valid information that we've brilliantly told about, this must be a tremendous help, of course, to the researchers, the people who eventually will, bring in the medication to combat all this. I mean, it's to know about all this and fit it into the pattern and replace it very adequately placed it. Must be very, very helpful. I know it's in the body, natural body to be there to be found, but if you integrate all that, surely that's going to be very, very helpful in the future, and I'm sure it's being worked on.
Yeah, absolutely.
By the researchers to do
Absolutely.
the process.
Yeah, indeed.
And this is why we're fighting at top level to get our share of funding for research, because we get a minuscule amount of percentage of the research.
It's not a sexy condition, is it? I don't think. And that's the problem. For want of a better expression, it's not the most glamorous of conditions, and that's why this kind of group is so important, and why people like Steve and Carol and everybody else that are working behind the scenes.
Well, the big C takes it over from, doesn't it?
Yeah.
Is above us in that respect.
I think lung health in general is not something that has got great sort of funding behind it anyway. But yeah, I think you're right to say that sometimes cancers do get more notoriety, if you like. Yeah. Okay.
And I'm sure that with the passage of time, we will get to that level. Let's face it, the progress we make with cancer and helping to reduce it. And I'm sure.
Fingers crossed. Fingers crossed, but it really sounds like that you guys in Bolton, and very ably supported, are at the forefront of what there is in the country and in Europe, by the sounds of it at the moment, doesn't it? You're an exemplar organisation, and let's hope that we can continue to move in the right direction. Okay, so we talked about all of those things that are now coming up on the slides. There you go, look at that, that's a nice picture, isn't it? So these are the goblet cells that produce the mucus, and these are those cilia, the hair-like projections that just sit on the inside of your breathing tubes and flick the phlegm via the mucociliary escalator. Okay. But sadly, we're not robots. I don't mean that, I wouldn't want to be a robot. But you know what I mean? The human body is flawed, isn't it? Despite all of that fantastic design and despite all of that working as well as it does the majority of the time, things sometimes go wrong, don't they? Okay, so one of the problems that we have for breathless people is that their pattern of breathing often changes. So people often stop being nose breathers and become mouth breathers. And it's partly to do with the ease of breathing. So you get a greater hit of air with less effort when you breathe through your mouth. And it's not the most effective way in terms of lung defenses, but sometimes that is the inevitability of needing more oxygen or needing greater air. Just to put that into perspective, it's perfectly normal to breathe through your mouth when you run. or when you
it's happened to
cycle.
me when walking.
Yeah, and when you exert yourself, it's perfectly normal. But if you don't have a lung condition, that should be the only time that you breathe through your mouth. The rest of the time you should breathe through your nose. So inevitably, if you've got a lung condition and your breathing pattern changes to you being a mouth breather, you lose one of those protective barriers, don't you? You lose that filter of breathing through your nose. So you get a faster hit of air that isn't filtered and is more likely to be to have a problem with temperature, particularly in cold air. Cold air really is not a great thing to hit your lungs. Okay, so that's one of the issues. That's one of the reasons why our lung defences break down. The second can be, oh, your batteries were almost okay. Sometimes if you develop a chronic cough, it can become less efficient. So actually, your ability to clear that mucus, which is normal and natural, is less effective. And that means that sometimes that mucus or that phlegm stays in your breathing tubes. And of course, they are dark and moist and the perfect place for bugs to grow. So you can develop an infection, which then in turn leads to further swelling and inflammation. And inflammation and infection are the two main causes of congestion in the airways and in the alveoli. Okay. So if you develop an infection, or if for some reason you have got inflammation of your airways, the cells that produce a small amount of mucus normally also become inflamed. And when those cells become inflamed, they produce more mucus. So the lungs are more likely to develop a problem with congestion. Okay. So if you've lost the filtration and your cough is less effective because it's a chronic cough, and you've got more phlegm being produced by those goblet cells because they are inflamed and infected, it's no surprise that sometimes phlegm does become a problem. And actually, it's not one of the core symptoms of pulmonary fibrosis, but all of you are at risk of getting a chest infection in the same way that everybody's at risk of getting a chest infection. But I guess your respiratory reserves are less if you've got a chronic lung condition in the first place. So really, we want you to...
I think you've explained something to me I didn't realise.
What?
So because I don't get, I'm thinking, what do you want about all this mucus? I don't get it, but I've got a terrible cough.
Yeah.
Right? So really then it's the mucus that just doesn't go anywhere, that gets infected.
Potentially.
Yeah.
Yeah,
That's
absolutely.
why I do get, I'm starting to get a few more chest infections.
Yeah, absolutely. So if you're not able to clear your chest as well as you might be
I
able
can't clear
to.
chest because it's nothing there.
Yeah.
I couldn't bring anything up, I couldn't pop anything up, there's nothing there.
Well, sometimes there's nothing there, but sometimes there's phlegm that's out of reach. And that's really what we're going to move on to in a minute, because I don't want to leave you without something that you can do to help yourself. So we will be talking about chest clearance as well shortly.
You know, give me a bit of an eye opener there.
Yeah.
It's the phlegm that that's just lying there.
Yeah, so if you're not able to, so you might have a normal process where that mucociliary escalator is working and you're just swallowing the secretions that you're creating. So that might be happening. Because it is possible to have a dry cough that's just really irritating and that's constant and it's there all the time. So that doesn't necessarily mean that your airways are full of phlegm that might then lead to a pneumonia, but certainly to be as good as you can be at clearing your chest, you need to consider doing extra things, I think. Okay.
So can I just ask you, today I heard the phrase, which I've not heard before, hospital pneumonia. You just mentioned pneumonia.
Yeah.
What exactly is hospital pneumonia?
Okay, well, it's absolutely the same as normal pneumonia. It just means that you picked it up in a hospital. Yeah, so there's loads of phrases that get used. We try not to use it actually anymore. We prefer to use a healthcare acquired pneumonia, because that might be because a district nurse has been to visit you and you've been, or you've been to a clinic for some reason. It's not always about a hospital, but certainly a healthcare acquired pneumonia is a real thing. Doesn't mean the bug's any different to what you would have got if you got that pneumonia at Hull, or you got it from Asda, or from Aldi, or whatever. But certainly, yeah, that is a frozen tumour. As the pneumonia. Yeah. We try and avoid Asda pneumonia. There's no antibiotics for that one. Okay, sometimes, depending on the cause of your chronic lung condition, sometimes those cilia, the hair-like projections, can also get damaged. Okay. Normally smoking related, to be fair, and we know that there is not a direct link between smoking and pulmonary fibrosis, but if you smoked in the past and you've got pulmonary fibrosis, you might have some damage to the cilia. They just don't work in the same way. So rather than working in harmony to pick up that phlegm and to work together to beat 20 times a second, they just sort of sit there and be a bit ineffective. So the phlegm can just sit on top of it while the cilia aren't really working in a harmonized kind of way. Okay. So they're the reasons why sometimes the lung defenses go wrong, and to help to explain why sometimes a chest infection can be more problematic than it would be in different circumstances. Any questions?
Is this not sometimes, because of our age as well, the industry we've actually been working, because obviously we didn't wear ear defenders with masks, and obviously today's generation is all health and safety.
Yeah, absolutely. Yeah,
people.
Yeah, so I sort of alluded to that, didn't I? So there isn't necessarily a direct link between any of that and pulmonary fibrosis. But if you've got pulmonary fibrosis and you've been exposed to those kinds of things throughout your working life or throughout your general living conditions, then absolutely it can have an effect. Yeah,
Because I was in woodworking and MDF is carcinogenic.
Yeah.
And I used to work in high local and TIC for 30 years. And you just.
So it may or may not have been a contributing factor, but certainly it's put you in a worse place than you would have been if you hadn't been exposed to those things, hasn't it?
So all these various conditions that we hear about, emphysema, asthma, COPD, IPF, obviously they're all connected in the same field. Although I understand that the medication required is different.
Yeah.
But is there not a common factor, common denominator with that type of condition?
So the common denominators that cause chronic lung disease are smoking, pollution, and breathing in stuff that shouldn't be in your lungs, like asbestos and like, you know, sawdust or cotton mill or stone. All of that kind of stuff are common themes for the causation of chronic lung disease. The exact mechanism for the damage to the lungs is different, and that's why the different conditions have got different names. So chronic bronchitis, or that form of COPD, is because the airways are inflamed. Emphysema is because those alveoli, the walls of the little air sacs, get destroyed. Pulmonary fibrosis is because of stiffening and scarring of the lungs. So they're all caused mostly by those things I've just described, but the treatment for each is slightly different because of the mechanism of the damage that's been caused. So the treatment for asthma, which again is to do with the constriction of the airways, is inhale therapy that helps to open up and relax the breathing tubes. Treatment for COPD is similar, inhale therapies. Treatment for emphysema is slightly different, and the surgery might be an option for some people. Treatment often involves steroids, and a lot of people in the room will have had steroids to help with inflammation and scarring, and that can be used for lots of different lung conditions. So we've got to be really careful that we understand that yes, all of those things can cause chronic lung disease, but there is a different mechanism that damages the lungs or the airways, and therefore different treatment is the more appropriate treatment for each one. Okay?
Two questions.
Yes. Would you like to ask first, and then we'll move on to
First one, how bad then is taking your walks where there's a lot of traffic?
So in an ideal world, it would be better to do your exercise where there isn't lots of pollution.
That's not possible.
No, so I guess we have to weigh up risks and benefits, I suppose, don't we? And the benefit to exercise is absolutely up there. So I would encourage exercise, but to do at a time when maybe there's less traffic and where possible to do it in an area where there's less pollution.
Second one is, my husband's got asbestosis.
Yeah.
So one of the risks of me picking that up, because I have read about it, and in dealing with claws and sitting around and all that kind of stuff.
I'm going to have to sort of profess a bit of ignorance. I'm not aware that there's any risk of you developing asbestosis from your husband having it. I don't think there's a link in that way, shape or form, but I haven't necessarily done any specific research around that, but I'm not aware of that as being an issue.
So there's no like secondary.
I don't think so, because I think the damage from the asbestosis happens to the individual, and that doesn't mean there's still asbestos in the lungs. That damage has been done, and that's not something that can be caused.
No, I'm not. The lot, because I've read about it on like the laundry and stuff.
Oh, you mean when he's been working, the cold has been working?
Oh, previously,
Yeah.
back in the day. Oh, right. So I guess there was a risk at that stage that you might also develop a problem because of being in contact with asbestos yourself from that. Sorry, I misunderstood what you were saying. Yeah, so I suppose there is a risk of that because you will have been exposed to some asbestos in clothing at the time. There is a risk, but it's probably a very small risk. I don't want to alarm you, and I wouldn't want that.
But there's other things to consider. Going back to when I was a youngster, my mother's ironing board, when we put the iron down, that was a sheet of asbestos, and that used to just flake up. So that is a risk. You know, these type of things we do find. It can
So
happen.
you probably find that's white asbestos that was on an ironing board.
Yeah.
And of course, there are two other types, one is brown and one is blue. The blue asbestos is the one with the little bars on, and that's generally used in, or used to be, not now. Blue asbestos was the one that used to wrap wires in, which is probably where you might have picked yourself up or whatever else.
Yeah.
Brown asbestos is sort of in the building trade, whereas white asbestos isn't. That's not usually. But that's used in ironing boards and things like that. That's the least risk, whereas the blue asbestos is the highest risk.
Did you want to ask something as well?
No, it's okay.
Are you okay? Are you sure?
Just to say that lady, my husband died of asbestos cancer, and I brought this situation up with the special, will be two specialists actually, to ask whether I got, because I've had an open lung biopsy, and I couldn't find out how I got it. Was it asbestos? And I was told this, that because I responded so well to steroids, that wouldn't be the case if my pulmonary fibrosis had been caused by asbestos. Yeah, but there is a little bit of asbestos in mine, according to them, but it's not the reason why I got it. So.
Would you have another question?
I worked in the building, I'm sure this gentleman over here was
Hypersensitivity pneumonitis.
I worked in the building construction industry all my life. I'm a joiner by trade, and I was diagnosed with asbestosis about 4.5 years ago, and they said it was mild. I've had a few chest infections. I had one about 3 months ago, which was ongoing. It took a long time to fix. And anyway, I had an X-ray, and I went to see the doctor only this week, and they originally told me that my condition was mild. The percentage was quite low, and I was told it was stable. Each time I had a scan or an X-ray, but this time the doctor told me there's been massive changes, and those changes
in my lungs, and it sort of just devastated me because, you know, I thought everything was stable and, you know.
I mean, she said it's so matter of factly, you know, as though we knew all about it.
We didn't know.
This is the one thing with pulmonary fibrosis, that people can be sailing along and then they get what we call acute exacerbation, which is what your infection was, and that did further damage, and that caused a dip and it increased scarring in your lungs. So you may go along now and stay at that level for quite some time, and you may have another chest infection, but it won't have the same impact as it had before. But it can do, you know.
Okay, yes, sorry.
Coming back, how long is it? A long time since pulmonary fibrosis was brought to the forefront. As you said, people didn't know what it was. I mean, I was diagnosed 7 years ago, so I didn't know that before that. It's an unknown quantity.
Yeah, I actually don't know when the phrase pulmonary fibrosis was first used. There's been lots of different names for it over the years.
So it's changed names.
Yeah. So there's always been, well, certainly in modern medicine, there's always been an understanding that there is a condition that causes that kind of scarring and restriction to movement. Well, there's been, one of the names was fibrosing alveolitis, which sounds similar, doesn't it? So the fibrosing bit is like fibrosis, and alveolitis, inflammation of the alveoli. Yeah.
Which you don't really know what it actually causes.
No, that's right. So that's just the way of describing that we don't know the actual cause of the pulmonary fibrosis. Yeah.
I mean, I had pneumonia when I was a teenager, which has actually scarred the lungs 7 years. I mean,
I think this is where researchers come in. They've, through the research over the years, they've found, I think, with interstitial lung disease, there are at least 200 causes or more. And that by the research, they've been able to categorize into different. But I know, I've known people who they realized, and considering that people are more or less in their 60s and 70s when they get the disease, that the parents, when they've looked back, the parents have died of it.
So it's very much an older person.
It does tend to be, but then you get people like Chris, who's a member, he's in his 50s, yeah. And now Chris is waiting. Yeah.
I also wonder, I mean, I don't know what our backgrounds, I came from very, really quite poor, you know, 2 up, 2 down, and outside, it was pretty poor. And you just wonder what you were exposed to. I remember as a small child going to the doctors, you know, with bronchitis and recurrence, and you wonder what you've been exposed to as small children. And yeah, I mean, things that have improved a lot in terms of like your industrial workers and protecting your health and safety and what have you. But there's still a lot of exposure when you look at the way, the sort of conditions that some children are living in. And is any of that carried on into later life? I don't know.
Yeah. And you wonder about black mold, that's in the press.
Black mold,
yeah.
I knew.
And poverty.
Yeah.
You know, poverty.
Yeah.
I knew of a doctor, he died unfortunately now, but he specialised in immunology. And he used to treat people for hay fever by neutralising, like doing allergy tests. And once he found what it was, then he could neutralise it. And he worked on people with hay fever. And the majority of people he was able to cure. But there were those who didn't respond. And he found that those people became worse when it was damp. And that's when all the mold spores have become airborne. And so when he treated them for mold spores, it cleared the condition.
Is there any research in any other country? Like,
oh yes.
Is it prevalent more in
I don't think there's more in anywhere else, is there?
No, but there's quite a lot, and they're looking at it from.
I think in the climate,
Well, I think it would make sense, and I'm not saying this with any great confidence other than my logical brain, that I would imagine there's an increased prevalence in industrial nations for the reasons that we talked about.
Yeah.
Right, but nothing to do with climate.
Less to do with climate, I think. Less to do with climate, more to do with industry, I would have thought.
Right.
Can we move on to chest clearance? Because I want to give you some positive things that you can do to help yourselves as well. Yeah, it's good to have some good news, isn't it? Okay.
This is your freebie.
Yeah, this is the free consultation. So there are a couple of things that will help you be as good as you can be at clearing your chest if congestion becomes a problem for you. Okay, so I think we've established it's not a problem for everybody, but most people at some stage will develop a chest infection or a pneumonia, whether it's hospital acquired or not, and will need to be particularly mindful about clearing the chest. So the first very simple thing that you can do is to make sure you are drinking enough fluids. Okay, any idea why that might help with phlegm clearance? Yeah, so listen, if you're not drinking enough, it's your whole body that's dehydrated. So those cells that produce that mucus layer will be producing thicker and stickier mucus, which is harder for you to shift. So simply by making sure you are well hydrated gives you the best opportunity of being able to clear that mucus because it's thinner and looser and easier for you to top up. So, well, listen, water is the best fluid. Yeah. Decaffeinated fluid is the next best fluid. Caffeinated fluid is not as good, and alcohol is the worst fluid. Apparently so, sadly. So drinking 10 pints of beer a day is not the solution. 6.5.
I would also add in there that milk and dairy products are not good because they are a mucus-based product themselves.
Yeah, so
if you're having trouble getting rid of mucus by putting more in there, that it's not helping. And when you think about it, humans are the only people who drink milk after being weaned.
So you're absolutely right. There is some research evidence that suggests that drinking milk is not great if you've got a problem with phlegm. Absolutely. For some people, it makes no difference at all. But it is something to bear in mind, isn't it? Yeah. So water's the best fluid. Squash, fruit juice, decaffeinated tea, caffeinated tea and coffee, and alcohol. That's the range. Okay. And we want to stick at this end of the range for the water and the non-caffeinated stuff. So 2 litres a day is about what people are advised to have, and the only proviso to that is if you've been told to restrict your fluid intake. Sometimes if you've got kidney problems, you will be told to restrict your fluid intake. Please listen to the doctors if they told you to do that. Otherwise, try and have a couple of litres a day, and more if you're exercising more, and more if the weather's hotter. Okay, so just bear that in mind. Second thing that you can do to help you be as good as possible at clearing your chest is to stay as active as possible. Okay, if you have a sedentary life, if you are chair-based, if you are bed-based most of the time, you are not getting enough expansion and contraction of your lungs. You're not giving those breathing tubes the opportunity to shake some of that mucus free. So exercise and fluids is absolutely the right thing to do. Okay. I am aware that it's not always easy to exercise if you are breathless, but there are ways to do it. There are ways to pace yourself. There are ways to control your breathing to allow exercise to be possible. Okay. So 2 relatively simple things that you can do to help yourself be as good as you can be at clearing your chest. We are all encouraged to do 5 lots of 30 minutes exercise every week, 150 minutes a week. Okay, doesn't have to be 30 minutes in one go. It can be 3 lots of 10 minutes spread out throughout the day. It can be 6 lots of 5 minutes. I've done my maths right, haven't I? 6 lots of 5 minutes if you need to. Okay, but it's about finding a way to be active. In the olden days, if you were in hospital for a hip operation, you might be in bed for a week before we got you out of bed and got you moving. Sadly, when we did that, you were more likely to develop a hospital-acquired pneumonia, and some people didn't leave hospital as a result. That's why we get people up on day one these days. Okay, so it's not because we're horrible, some of them are, not my team, the orthopedic ones are horrible. But we do try and get people up and moving because we know it's the best thing to do in terms of preventing congestion and infection in the lungs. Absolutely, yeah, there's loads of reasons why exercise is good, particularly post-op, absolutely, blood clots is one of them. Okay, has anybody ever been taught any specific chest clearance exercises? If I say the words, the active cycle of breathing, has anybody heard about that? That was going to be my next question. Has anybody heard the word puff used? Okay, this is probably the first breathing exercise that a physio will teach you if you've got a problem with clearing phlegm. So I'd like to go through that exercise with you now. Okay, it's really, really, really straightforward. I'm not going to get any of you to do any huffing. In the olden days before COVID, we used to do that, but it's probably not the best thing to do these days for us to be sharing all of those 2.5 million sextillion molecules of air with each other anymore. Okay, so I'm going to fast forward to the active cycle of breathing. Okay, ACBT, active cycle of breathing technique. And the whole point of this exercise is to improve the efficiency of a cough. Because when you cough, you only really catch what is within reach of the cough. And it's often the phlegm or the mucus that's just sitting here. If you've got a build-up of phlegm down here, or here, or here, or here, or here, it's much harder for you to cough that up. And that's why people often feel that they can feel it in the chest, but the cough isn't helping. Okay, so the whole point of this exercise is to allow the phlegm to move to a place where the cough has a better chance of clearing it. And we do that by, first of all, concentrating on simple, relaxed and gentle breathing. Okay, we want your airways to be as relaxed and as open as possible, so that when we do some deep breathing in a minute, we've got a better chance of that air getting right the way throughout your chest. So a physio will always say to you, do 1 or 2 minutes of relaxed and gentle breathing first. Nothing fancy. Thinking about relaxing your shoulders, relaxing your tummy, and making sure you're not gripping on for dear life with your arms, so that you can just breathe normally and quietly and calmly. Once you've done 1 or 2 minutes of gentle, normal breathing, the physio will then say, I'd like you to do some relaxed, deep breathing now. And the point of the relaxed, deep breathing is to get air right the way throughout your lungs. Okay, it's to get air behind that potential build-up of secretions that are sitting in your breathing tubes. If we don't get behind them, it's much harder to move them. Okay, so again, nothing fancy. And you must try and stay as relaxed as possible. And you can all practice this actually. Just put your hands on your tummy. Okay. And I just want you to keep your shoulders as relaxed as possible and just try and breathe into your tummy so that your tummy gently rises and falls as you breathe in. Okay, so a nice relaxed deep breath. And then out again. We'll try again. And out again. Great stuff. And if you can feel a rise and fall of your tummy, that means you're getting air right the way through your lungs because your diaphragm's working. Okay. If you can only feel movement at the top of your chest, it's going to be harder for you to get air behind some of those secretions that are there. So just to recap, gentle breathing first to give your breathing tubes the chance of being open, and then relaxed deep breathing to try and get air behind the secretions. And then we come to the huff. So a huff is a fast blowout with an open mouth from the back of your throat. So a little bit like fogging up a mirror, if you were just going to give a mirror a polish, or if you were going to clean your specs. It's that kind of a technique. And what happens when you do the huff, it changes the pressure of the air inside your breathing tubes and sort of squeezes the phlegm further up your breathing tubes to a more central position. So you can do a big huff from a deep breath. I'll do one of them again. I feel a bit lightheaded sometimes when I do that. Or you can do a smaller huff with a smaller breath. And actually, you probably need to experiment a little and play around with that a little bit to see what works best for you. Very often when you practice that, you'll get the urge to cough because actually you've moved some phlegm that was sitting there. And if you do get the urge to cough, it's absolutely fine to do the coughing. So the cough is the last bit of the cycle, okay? Relax breathing, relax deep breathing, puff, 2 or 3, followed by a cough. That will be one cycle of the active cycle of breathing. At the end of that cycle, if you can't feel any rattle, if you can't hear anything rattle, if you've got a dry cough, chances are there's nothing for you to clear, in which case you can leave it, okay? If you can feel a bit of a rattle, if you know there's something there and you've not quite got it, if you brought a little bit up, but you think there's more there, you can just repeat that cycle as many times as you need to. But always go back to the gentle breathing first. Because if you do too much deep breathing, too much huffing, too much coughing, the breathing tubes might tighten up. So let's give ourselves a chance for the breathing tubes to relax and to open up again before we repeat the cycle. Does that make sense? It's a really nice breathing exercise. You don't need any equipment. Nobody needs to do it to you. And it really does work. Okay, the huffing. And you know what, I've spoken to a lot of people. As I said at the beginning, I've been doing this job for a long time now. Lots of people learn how to huff themselves because they find it works for them. So nobody's taught them to do it, but they've just worked out over the years that that's something that helps. Okay, so the active cycle of breathing. If you Googled it, and feel free to Google it, you'll find loads of similar explanations. They all give the same kind of information. So feel free to do that.
And then one person will say, recommend you do not do.
Yeah, so listen, you have to understand your body, don't you? So this is often used for people with COPD and bronchiectasis. Okay, that's a condition where lots of phlegm is created. That's part of the mechanism of it. For those people, we often say do it twice a day, do it 4 times a day. Okay, probably less required with pulmonary fibrosis to do it as regularly as that, but you could do it twice a day. You could do it when you get up in the morning and before you go to bed, okay? And then you know, at least you've given yourself a decent opportunity for your chest to be clear. But certainly, if you feel a chest infection is coming on, that's when you want to be more careful about doing something more regular to clear your chest, yeah. I often say to my patients who use an inhaler 4 times a day, why don't you use your inhaler and then do the active cycle of breathing afterwards, okay? So if you use an inhaler, and I know that it isn't necessarily what's prescribed in pulmonary fibrosis, then that might be something that you choose to do. Because the inhaler helps open up your breathing tubes, and to me it makes sense to open up your breathing tubes first before you then start to clear the phlegm, because it's much easier to clear phlegm through a nice big open hole than it is through a tight breathing tube. Okay, so that is the mainstay. So we've talked about fluids, we've talked about keeping active, and we've talked about the active cycle of breathing. There are other things you can do to help clear your chest. Anybody ever seen anybody with cystic fibrosis having chest physio? What do they tend to do? They tip them upside down and they bash them on the ribs or on the back. Absolutely. And actually, they are techniques that do work for some people. So the tipping upside down, or the tipping on your side, or the holding the little kids by the feet and letting them dangle is called postural drainage. And it works on the principle that there are loads of different areas of your lung that all drain in different directions. So if you are upright, sitting upright, the breathing tubes that are at the bottom of your lungs, the phlegm is more likely to pool because of gravity. Yeah? If I tip you up by your feet, you've got a better chance of draining the bottom of your lungs. If you lie on your left-hand side, you've got a better chance of draining any phlegm in the right lung. If you lie on your right-hand side, you've got a better chance of draining the phlegm in your left lung. If you lie on your right side and you put a pillow underneath your bottom, you're tipping yourself up a bit even further, you've got a chance to drain the stuff from your left lung and from the bottom of the left lung. Do you see what I mean? There's about 12 different positions. I think there might be more than 12 different positions. But we normally say to people, if you can tell that you've got phlegm on one side of your chest, and if you've got pneumonia on one side of your chest, you might know that, then it's worth targeting that area of your lungs. If you know the phlegm is out of reach, it might be worth tipping yourself up slightly. I often tell the story, I had a patient, and we'll call her Edith. She's not called Edith. But she had a condition where she brought up a lot of phlegm, and I remember having a student physio with me, and I went to see her, and I knew that she knew what she was doing, and I said, Edith, could you show my students what you do to clear your chest? And she said, of course, Tom. Bearing in mind she was in her 80s and almost had a heart attack. I would have called on you. She threw herself over the edge of the bed into a press-up position. So her legs were on the bed, but she was literally dangling off with her arms on the floor. And she said, this is what I do every morning, Tom. I tip myself upside down and it just flows out of me. It's a nice image, isn't it? And I think my student was a little bit shocked by this, but it just goes to show that for some people, gravity can have a major impact on their ability to clear areas of their chest. 10 minutes is often the required amount of time for the phlegm to have a chance to start to move, but it's worth experimenting with. And we often in the hospital, we just say, why don't you lie on your right-hand side? And then stay in that position for 10 minutes and then do the active cycle of breathing. The combination of the two things is likely to make you more effective. Try the opposite side to see if that works best. There's an element of trial and error if we don't know specifically where the phlegm is, but sometimes you can feel it, sometimes you can feel a bit of a rattle, you can hear a bit of a rattle, you might have an idea. So postural drainage is a good thing just to have in the back of your mind. And then the percussion, that rhythmical clapping with a cupped hand, can also help to physically dislodge some areas of some of that phlegm that's sitting in the breathing tubes. Normally, it's better if somebody does it to you. You can percuss the front of your chest. It's harder to get round to the other areas of your chest, and it's certainly harder to get to your back. And we often combine the two things. So we might lie somebody on their side, and then the physio might, with cupped hands, do percussion. Okay, we never do it on bare skin. We always make sure there's clothing or a towel there just to cushion it a little bit, because we don't want to cause any tissue damage. But it's one of those things that you might want to consider. And you, as I say, you can do some self-percussion, but always with a cupped hand, not a slap. Okay, so you're not slapping yourself. You're trying to get a bit of sound vibration that helps to dislodge that area.
One thing I would say, if you want to use that technique, is if you stand up and just let your hands hang by your side, and then just bring your hands up, and you've got that natural cup. You don't have to try and get into a position, just let them hang, and you've got it, and then it can.
It's worth thinking about. Okay, so we've talked about exercise, we've talked about fluids, we've talked about the active cycle of breathing, which you may or may not do in a postural drainage position after somebody's done some percussion. There's quite a few things going on there. The last thing I wanted to show you was just some adjuncts, some bits of equipment that can be helpful to clear your chest. Steve, I managed to find a footer. I wasn't expecting to be able to find one, so I've called in today via our clinic, and as I say, we thought they were all out on loan, but they weren't, so I've managed to bring the footer. So there's two devices I just want to show you. One of them, the flutter, is definitely available on prescription. It's also definitely available to buy. My experience is that if you go to your doctor and ask for them to prescribe you a flutter, they won't know what you're talking about. And some of them are reluctant to prescribe it, okay? But it is available on prescription, so you don't have to go and buy one, okay? It's a little pipe that you blow into. I'll show you. There we go. It's a funny little device, you know, because it's just made of plastic and it's just got a ball bearing in it. So I'll show you. I'll open it up and show you. So just a plastic pipe with a little cone and a ball bearing. Plastic pipe, a cone and a ball bearing inside it. Okay? Would you believe how much these cost? What do you reckon? Plastic pipe, bit of a steel marble in there. 55 quid. 55 quid. And that was the last time I looked. Cost of living, they've probably gone up to 69.99, haven't they now?
Last time I did 65.
Well, all right, so there you go. They have gone up since I last looked. But they are available on prescription. And they can work for some people. Okay, so they don't work for everybody, but they can work for some people. And it works on the principle that as you blow into this tube, you get a back pressure of what you've just blown out. So you get some back pressure, which helps to splint open your breathing tubes. Okay. And we've already said that an open breathing tube is the best kind of tube if you want to clear phlegm. So it does that job. You blow out against the resistance of the ball and you get some back pressure in the lungs, which splints open the breathing tubes. But it's also got this little ball bearing in it. And when you blow into it, the ball bearing oscillates. Okay. And it's why it's called a flutter, because it sounds like a fluttering noise. But if you're doing it right, you also feel the fluttering in your chest. And what's happening is that the phlegm or the mucus that you are naturally creating, or you have excess of because you've got inflammation and infection, shakes free from the wall of your breathing tubes. And then if you huff and cough, you've got a much better chance of clearing it. So I can't let you all try it because that would be an infection control disaster. But I can do it just so you can hear it. The trick is to make sure you've got an open airway. And actually sometimes just to tilt your chin slightly opens up your airway. So you've got a better chance of this working. So if you're sitting in this position with your head down there, it's not likely to work. If you're in that position, it's more likely to work. So have a little listen. Hope I can do it now. Yeah. So clearly, you've got to take the deep breath first, don't you? And we've already said that a deep breath's important to get behind the phlegm, but when you blow out against the resistance of the ball, your tubes are splinted open, and that fluttering sensation helps to move and to mobilize the secretions. If you read the Gumph in the literature that comes with it, it says it's like shaking apples off a tree. So if that's helpful to have that in your mind, the flutter is a bit like shaking apples off a tree. Okay, slightly different to bread and butter, but there you go. So that's one of the options. The other option, which does half of the job, is this little gizmo called an incentive spirometer. Have you got one of these? So I'll show you what this is like. Now we give these out very frequently in the hospital. It's a really nice little gadget for people to use. The cheap ones are used to encourage a deep breath. Okay. So these are the cheap ones. These are quite often given to people after they've had an operation. And the physios will come around and say, suck on the end of that, and as you suck on the end of that and take a deep breath, the blue line here lifts to the top of the chamber. And the idea is that it encourages you to take a deep breath. Okay. And that's important after you've had an operation because we don't want you to get pneumonia. Yeah? Yeah, loads of people have got these. They're given out willy-nilly. These cost about £5, I think. This fancy one here costs a little bit more. And the reason why it costs more is it can be used in two ways. It can be used exactly the same as the other one, in that it can encourage a deep breath. So we have it set up like it is there. You hold it out in front of you and you take a relaxed deep breath. So you suck on the end of it. And as you do that, the ball lifts to the top of the chamber, and the idea is that you keep it there for 5 seconds. So you're taking a nice, long, deep breath. And there's different levels of difficulty, and you just simply move the dial around. So level 5 is the hardest. It takes a bit more effort to keep the ball up. Okay, so we would encourage people to do that, and we might say do 5 of them or do 10 of them 3 or 4 times a day. And that's purely to encourage a deep breath, to prevent the buildup of secretions, to allow air to get behind those secretions to move them. What this gadget does nicely though, is you can swap it around, and it's really technical. Look, I pull the end off, I pull the top off, and I swap them over. Okay, I swapped them over, but what I must remember to do is just to turn the cap round to the yellow side. And now, when I take a deep breath and blow into the machine, I'm blowing out against the resistance of the ball, which helps to splint the breathing tubes open. The difference between this and the flutter is that I don't get that fluttering sensation, but I do still get the benefit of the breathing tubes being open. And after I've done that, so I might say to my patient, do 5 deep breaths, set in the original way, swap the machine around, do 5 blows, follow that with a huff and then a cough, and do that 3 or 4 times a day. And that gives you the best opportunity of being able to clear the chest. Okay. So it's an alternative to the active cycle of breathing, because it's really doing the same kind of thing, isn't it? But with the added bonus of getting that splinting open of the breathing tubes. Any questions on that?
What if you don't cough anything?
Yeah, so if you don't cough anything up and you don't get chest infections, you don't need to worry. Okay, so sometimes people will be swallowing those secretions, in which case it's not a particular problem. And for some people, it's hard to say, isn't it, really? So I guess what we would say is, if you do everything that we talked about today, make sure you're well hydrated, make sure you stay active, make sure you do some breathing exercises, it puts you in a better position to be able to manage it if secretions become troublesome. Okay.
So do you have a tickly cough?
Okay.
Do you have a tickly cough?
No, I want to get a chest infection, because it was weird. The doctor said you coughing anything up. I said no, but I had a weird like cracking cough and nothing.
No.
But I've always been like that when I have a chest infection.
Yeah, and some people are.
Yeah.
But you've got a few things up your sleeve now, haven't you, to make sure that you're using as options to put yourself in the best position. So it might be that if you lie on your side with a pillow underneath your hips, that might help gravity and move something if there's something there. Some people, when they get an infection, it can
like a cracking.
well, it can do, but normally that you'd only really hear that if you had a stethoscope. So your doctor will be able to hear a crackling. If they were to auscultate or listen to each other.
They can tell, I didn't know this, till chest infection. They can tell whether you've got an inflammation under infection. Because I couldn't understand why I was being given the antibiotics, but they wouldn't take the steroids. And I asked, I said, well, usually, I've got on steroids. And said, oh, you haven't got the inflammation. You've just got the infection. I've got it the right way around. I've only had the one.
Interesting that.
Yeah.
I'm not going to say much more than that's interesting, because normally with infection comes inflammation, so it's unusual to be given one.
Yeah,
and not
but
the
they said that they can hear the difference. One's like something like walking on snow, practice snow.
No, it's
and another
true.
one was something else.
Yeah.
Yeah, but I've usually had the two. Usually have the up on the steroids and the the antibiotics. Plus as well, I don't know if anybody here, I was told by the specialist that a week's antibiotics is not enough for people like us.
Normally it's more that's required. Yeah.
Yeah. The GPs often people a week.
Yeah.
Because they don't really know the condition that well.
No. So to summarise, that's pretty much it in terms of congestion and chest clearance. Okay, Steve, I did do one slide about dry cough, And I must admit, I'm not an expert on dry cough, so I've just done a little bit of reading, and really all I'm going to offer you is some common sense, if you like, and it's probably stuff that you might be doing already. But we do know that lots of people just have a dry, irritating cough when they've got pulmonary fibrosis. So I'll have to skip through most of this because I just ad-libbed it. Will you be able to share the presentation with people anyway? So you guys can have a look at it in your own time. Oh yeah, there are some other things. Saline nebulizer, steam inhalation can also be helpful with phlegm clearance. So if you've got a chronic cough and it's wet, and I don't like using that phrase, but it's one that's quite descriptive, isn't it? Then you can do all of that chest clearance as we just talked about. Okay. If you've got a chronic cough and it's dry, that can be quite disabling, can't it? And it can be quite difficult to lead a normal life because you're less likely to want to go to a concert, you're less likely to, and you get pain, you get all sorts. So you've got to be really careful with this. If you've got a chronic cough and there's phlegm on your chest, you definitely should be clearing your chest and coughing, that's fine. But that sort of tickly, annoying cough that's there in the background, if possible, you need to voluntarily stop yourself from coughing, and that's really hard to do. And I absolutely know that's really hard to do. But there are ways that can help with that. Having a swallow instead of coughing can be helpful. Lots of sips of drink. Every 15 minutes, have a sip of drink. That can be helpful. Steam inhalation can be helpful. Okay. Breathing through your nose, if you can do it, can be helpful. Because often, or sometimes, that chronic cough is because you're getting a direct hit of whatever you're breathing. And if you breathe through your nose, you've got about an extra 10 centimetres of tubing for the air to go down, 12, 15 centimetres for some of us, which slows down the air that you breathe and warms and moistens and humidifies what you're breathing in. Maybe just to move the cross stages. Yeah, so gentle breathing, pursed lip breathing can be helpful. Is everybody aware of what pursed lip breathing is? Some of you might do it automatically. It's basically where you have a bit of pressure around your lips, as if you're about to whistle, but you adopt that position when you're breathing out. So you breathe through, you blow out through your pursed lips. Just out of interest, anybody know why you do it? Do people do it naturally when you're breathless? Any idea why? It's because sometimes when you breathe out, at the end of the breath out, your airways can just collapse over, which makes the next breath in really difficult. If you breathe out through pursed lips, you generate a little bit of extra pressure in your breathing tubes that just keeps them splintered open and stops that collapse. So it's a really nice technique to do if you're breathless and you're trying to do some exercise or to exert yourself, blowing out through pursed lips. And that just means a bit of pressure through your lips. But it can sometimes help with a chronic cough. Sucking on a sweet is a good idea, but interestingly, not a medicated lozenge. Medicated lozenges actually can make a chronic cough worse, I've read. So avoid medicated lozenges. Okay. So something fruity. Well, listen. If they help you, that's absolutely fine. But as a general rule, I think the medicated stuff in the lozenge isn't so good. It has a drying effect. Yeah. So just to be aware of. Sucking on an ice cube. There you go. Nice in this weather, isn't it? Nice with the gin and tonic. But just having that cold fluid at the back of your throat can help with any inflammation, because a chronic cough causes inflammation in the vocal cords as well. Avoiding caffeine and alcohol. Sorry, 6.5 pints. But again, that can have a drying effect and can make the chronic cough worse. And trying to avoid any known triggers. So if you know you are worse in the cold, then sometimes it's worth having a loose fitting scarf around your mouth when you go outside. If you know that certain perfumes or aftershaves trigger a cough, obviously you want to try and avoid them. Some deodorants can be like that, can't they, and body sprays. So it's just being aware of that and just having that in the back of your mind. They are some of the things that can help with the chronic cough. And I'm sure you all have got your own things that work for you. And this kind of a group is a really good forum for you to share those kinds of ideas as well, because you often find people pick up stuff from peers as opposed to healthcare professionals. So absolutely use this kind of forum to share simple tips like that. So, has anybody got any questions? You've been a very wonderfully vocal group in a very positive way. But does anybody feel they've not had a chance to say anything? Yeah.
When I stopped, I could blow my nose, but since I stopped running, I'm blowing my nose when I'm walking all the time. Never needed it going while I was running.
Right.
Never ever. But once I started walking, just blowing all the time. Why?
I'd love to say I have an answer for that, but I'm afraid I don't. You've stumped me. One thing, absolutely.
Yeah. I just want to tissues all the time.
Well, the nose and the sinuses are a mysterious place, a cavernous, mysterious place in our brains. We're one of the few creatures that have such a big hole in our heads where nothing much goes on. If only those could be filled with brains instead of science cavity, we might be in a better position, mightn't we? I can't answer your question. I'm sorry.
You're not on medication, are you? Are you on Biosopro by any chance? Because that causes.
Are you on
a beta? Right.
I'm on a beta rock and beta.
Well, check the side effects, because I'm on Biosopro, and I've a sort of problem where I'm really not.
So post-nasal drip can be a real problem, and it can be something that you develop later on in life. So there is a
check the side
Did
effects.
you want to ask a question?
Can I ask what is hyperinflation of the lungs? Is that different to what?
Yes. Yeah, so hyperinflation of the lungs is normally more common with emphysema than with other lung conditions. And it's because the alveolar wall gets damaged, and instead of looking like a nice, perfect bunch of grapes, it's more like little balloons that have been popped, if you like. So what happens is people tend to breathe into the lungs, but the exhalation mechanism doesn't work quite as well. So you tend to get air trapped in the lungs, which on a chest X-ray looks like hyperinflation, and over time it can cause a change to the shape of your chest. You can get a barrel chest, and maybe you can get different deformities as a result of hyperinflation. But yeah, it's a separate thing to fibrosis.
Like COPD?
Yeah, so emphysema is one of the two main forms of COPD. Anybody, anything else for me?
It's very enlightening. And the problem is that my wife has COPD, and I was listening very intently to your escapade with Edith.
Edith, yeah.
Throwing yourself on.
Absolutely.
I mentioned that to my wife, you might snap around
She might, but she might say to you, you know what though, I've noticed when I clean the bath, that's when I cough more. Because that's one of those positions where you naturally tip yourself up, and people often are able to then start thinking, oh actually, yeah, when I'm bending over to clean the toilet or bending over to clean the bath, that is when I tend to cough more. So yes, quite often people unwittingly have the effect of gravity.
Lovely.
I think Steve's going to share the presentation.
The presentation, I'll print them off so that you can get a copy. Yeah. What I can do, I'll just make sure I've got your email addresses, and then what I can do, I can email them to you so they can print them off. Yeah, and also I've recorded the session, so it will be available on YouTube, so you can go through it again. So,
okay,
lovely,
brilliant.
Thank you ever so much, Tom. I love that was explaining things. And what I have found, and I don't mean this disrespectfully, but it is that I know that Tom didn't start off his career as a physiotherapist. He went through other ways, and I find that people like Tom are far more able to explain and relate it to life than those students who've gone from school into university and then into a career. They've gone through academic and they've not got those same life skills. And that does make a huge difference.
So
I think that's really good questions as well.
yeah, brilliant questions. Absolutely fantastic. Depth of knowledge, but also, you know, curiosity as well, which is great. So yeah, my original background, I did a geography degree many years ago. And then I thought I might be a teacher, but I didn't want to go straight into teaching. So I went and worked in a school down in Cambridge, a school for children with cerebral palsy and profound learning difficulties. And I thought I'd just be there for a year, but I ended up staying there for 4 years and met my wife and got married. And then I moved back up north and did my physio training. So yeah, I'm about 7 years behind where I might be in other ways. So yeah. So I do have a bit of a different background before I became a physio.
Thank you ever so much, Tom.
My pleasure. My pleasure.
It's always a pleasure to have you. Now, I've got a few things to go through. Some of you will be aware that you can access the Withenshaw support group, which is on Microsoft Teams. In the email that I sent you the details. Unfortunately, I had it as the 8th and not the 18th, but anybody can join that. It's well worth joining and speaking to the respiratory nurses from Withenshaw. They come up with an awful lot of interesting information. Okay, thanks, Tom. Thank you.
Thank you.
We talked about home oxygen last time, and our friend over there, Neil, he said he would look into things, which he has done.
Yeah, sorry.
What?
My son-in-law, so I took the opportunity after you raised it last time about you talking about oxygen cylinders and sizes and not being able to
Oh yes, I'm looking at that.
all right, so I raised it with him, and he said, well, look, just put everything together. He said, if you've got any issues about oxygen cylinders, about interchangeable, or whether they're the wrong size, or whether they're the right size, or whatever else, he said, if you have any comments, then if you give them to me, then I'll raise them. But what he said was that he would raise it with the domestic oxygen manager at VLC, who sits on a group of the 4 suppliers of domestic oxygen. So really, what you were raising last time about interchangeability, that shouldn't happen. But if it is happening, then this is the forum to raise it.
I can tell you if you tell me.
Yeah, I know. I think, but let's have another go. If we start off with the managers, at least we might be able to do something.
We're not done.
And be positive for everybody else.
Yeah, I don't think they necessarily have to be standardised, but just has to be some common sense.
Well,
There's no common sense.
no, you see, I take common sense, that it means they have to be standardised. And because if it isn't standardised, then it isn't common sense and people have an issue.
Standardisation costs money.
But well, it does, but
Yeah,
let's overcome that
no.
if we can. But one of the things is that if you have a larger cylinder and a smaller cylinder, one from one company and one from another, then you should be able to interchange them. And the cylinder that goes to the larger cylinder company, which is the smaller cylinder because it's interchanged, they just bundle them all up, stick them in a bag, and take them back to them that they have at the present time. Now that might not work, so we have to make sure that it does work, so that there aren't any cylinders here that should be over there. It's very simple.
It's not strictly that. It's the increment. It's the increments. If you go in Derby area, which you find sons and Surrey, they're not going up. You know, when you get to 6, they're not going up 6, 8, 10. They're going up 5, 7, 9.
Well, let me know, and I'll take it up.
Yeah.
It's dead simple.
Yeah, because that's what happened. You see, what happened was when I was requesting a baby to say I was watching around the sons, and when I rang when I rang up and checked with Bolton, they said, oh, well, you said your prescription matters can't work. Because you're on 8 leases.
Yeah.
And we only do 5% on that.
I'm
No,
not entirely sure.
and then they want
The final one that we agreed on. But anyway.
That's
how
the ancient
Oh, right. I don't know if that was on the bottom. Anyway. She made some suggestions. Well, anyway.
Can I? Yeah, that's fine. Thank you very much. I'm conscious of the time. We're running late, and we've got other things to do. Yeah. Okay, we've got the latest batch of membership cards. So if you see, James, we've got them there, so you can pick up your membership cards. The other thing is that you may or may know that James is starring in Evita at the Lowther Pavilion in Lytham. And I'm going to go along if anybody is interested. It's a Saturday, there is a Saturday matinee, which I think will be brilliant, which is on the 17th of June at 2:30. And I thought after that, I'll maybe go and have an afternoon tea or something like that. I can book a block, but it's a maximum of 10 tickets in a block, and it's £15 per person. So if anybody wants to go, let me know ASAP so that we can get a block. I've looked at the map and the seats are going fairly rapidly, so to get a block together, I need to know fairly soon. We've talked about the pulmonary hand classes changing.
Where's the venue, Steve? Sorry.
Lytham.
Oh,
Yeah.
right.
Yeah. Yeah. Now, on the Thursdays, not next Thursday, but starting the Thursday afterwards, I'm going to be running a spirometry clinic. So anybody who wants to have a spirometry test, who's not had one recently, then let me know and I will book you in for an appointment on the Thursday mornings that we normally have the pulmonary rehab. So we can have a session there. I'm hoping to do about 3 people in the time. Support group committee, I'm conscious that we've not had a meeting since the AGM. So I want to, for those people who are on the committee, to let me know what is the best day and time. I think Zoom will be better, would take less time than sort of people travelling to a venue, etc. So if you email me and let me know when it's convenient for you to do that, then we'll get that sorted out. Our next speaker is Jackie White from the hospice here, which is going to be very useful. Also, it was mentioned a little while ago, the Bradshaw Brook duck race. Now, we've got tickets here. And I would like you to be able to sell tickets. Now, what happens is it's sponsored by various companies and they've donated the prizes. And there's up to £1,000 worth of prizes. The tickets that you sell will be entered into the duck race, but the money we make from the tickets comes directly to the group and not to any other charity. So the more tickets you can sell, then the more it will bring into us. So if anyone wants to take tickets, there are several books there. If you want to take a few books and sell them to your friends, that would be absolutely brilliant.
We've actually had printed 18,000, and this year it's been going extremely well.
Yeah.
In fact, some people, I mean, there's one lady there who sold over £1,000 worth already, and it's a collective of churches in Harwich. And as I said, every penny goes towards your charity. We support 51 charities in the